Welcome to today's MESUD Learning Community Echo. Today we'll be hearing from Dr. Alane O'Connor on methadone and pregnant people. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And now I'd like to give a quick introduction to our speaker today. Dr. Alane O'Connor is the Director of Perinatal Addiction Medicine at Maine Medical Center and is the medical advisor of the Maine Maternal Opioid Misuse Initiative. Dr. O'Connor has more than 15 years of experience in addiction medicine and in a variety of settings, including the design and implementation of an extended release buprenorphine pilot at the Somerset County Jail, rapid access to substance use treatments in emergency departments through the Maine Medical Association's Project RISE, as well as an extensive experience in caring for pregnant patients with substance use disorders in both the inpatient and outpatient settings. And with that, I will hand it off to Dr. O'Connor. Thank you all for being here today.
Good morning, everybody, or maybe it's afternoon now. Great to see you all. I'm coming to you today from the jail, so I apologize in advance. Jails are very concrete-y and there's a bit of an echo, but we'll do the best we can. This is a quiet spot. So I'm going to talk to you today about methadone and pregnant people. These are just the objectives. We're going to talk a little bit about evidence-based best practices for screening for substance use disorder and pregnancy, as well as ways in which you can talk about the implications of substance use disorder and pregnancy with your patients. We're going to talk a little bit about kind of what is known about maternal and infant outcomes following the use of methadone during pregnancy. And then I'm going to talk a little bit about issues that are specific to pregnant patients with opioid use disorder. So as you're seeing these patients in practice, different things that may come up: delivery planning, pain management, breastfeeding, hepatitis C, and a number of other issues. So I wasn't really aware of this echo, but this does look like it's been a great echo series. So I'm not going to get into the weeds on a number of things because it looks like you've already had this content. So as many of you know, and I know that a lot of you come today from methadone clinics, it can be initiated on the inpatient unit, but must be continued at a federally licensed outpatient treatment program. This does limit access, I think, especially in rural areas. We take care of a lot of folks at Maine Medical Center, for example. We take care of a lot of folks who live in very, very rural areas. And so it's hard for them to continue. Initiating pregnant people on methadone is not meaningfully different than non-pregnant people. And in my experience, the number one reason, unfortunately, patients quote unquote fail methadone is that they cannot get there. So that is really something that we need to think about as we're caring for folks. In the age of fentanyl, starting patients on methadone is far simpler than starting patients on buprenorphine. This is universally true. I think in particular, people are fearful of precipitating acute withdrawal, introducing buprenorphine too early, too quickly. And that is sort of compounded by the fact that people are more concerned when folks are pregnant. Methadone also has significant pharmacokinetic interactions with many other medications, fluoxetine, antiretroviral agents, and can prolong the QT interval, as you all know. So just that should be considered before you're starting any new medication. So that's kind of the overarching what you already know. And now we'll talk a little bit about pregnancy. Next slide. So screening for substance use disorder in pregnancy should be universal, and that's recommended by a whole host of different organizations. We recommend an evidence-based verbal instrument, such as the 4Ps is probably the one that's most commonly used. ACOG recommends that, as do others. It's a pretty generic set of questions. So it captures most people with a substance use disorder. It sort of also over-captures people in the sense that people may have a parent who had a substance use disorder and they themselves don't. But I actually really like it because it's sort of open-ended and can start a dialogue that people are often uncomfortable having. There's a lot of confusion out there about universal urine toxicology testing. There's certainly a place for that, particularly when folks are in treatment. But the use of it as a screening test is not recommended, particularly in pregnancy. And I see this a ton in a variety of different settings. People will get a urine to even test for pregnancy, and it will get sent for toxicology testing kind of without the patient's consent or knowledge. And then it really creates a problem on the other end. So just an awareness that if you are doing toxicology testing, you need to be talking to pregnant patients about it, certainly if it's outside of the scope of what you're normally doing. Pregnant people are very highly motivated to engage in treatment. This is the joy of working with patients who are both pregnant, frankly, and incarcerated, is that this is a population who tends to really want to get well. But pregnant people are really worried about what's going to happen. If I go in and I talk about my substance use, are they going to take my baby? Certainly society shames pregnant patients, I think even more than patients who are not pregnant with substance use disorders, and they experience a lot of stigma. The standard of care for opiate use disorder during pregnancy is absolutely medications for opiate use disorder. Patients will commonly say, I don't want to be on anything at all. So they'll come in to see me. They'll just have learned that they're pregnant, 8 weeks. They'll say, I don't want to be on any medications. I just want to stop everything. And I totally understand the motivation there because they're thinking, I don't want to expose my baby to anything. But we really try to discourage that, in part because, as you all know, the risk of stopping anything cold turkey is very risky from a risk of subsequent overdose perspective. We also know that people who are continuing treatment for their opiate use disorder are more likely to obtain prenatal care. You'll also find patients who say, well, okay, I'll stay on the medication, but I want to keep my dose as low as possible. We have a lot of conversations about the fact that actually as the pregnancy progresses, they'll probably need more, not less of their medication. And the best dose is really the dose at which patient has no cravings or withdrawal. So we know that untreated substance use disorders associated with a variety of high-risk patient behaviors, sexual illegal returns to use. And the other thing that's important to teach patients, which is probably on a different slide, but I'll say it here, is that there's no dose-specific response to the infant's withdrawal syndrome postpartum. So patients will say, oh, I only want to stay at this dose because I don't want my baby to have a more severe withdrawal. And I'm using quotes because these are words that they would say. And there's really no evidence to support that. So people will often feel reassured that they can increase their dose if they understand that the baby's experience isn't necessarily going to be any different. We do want to avoid acute withdrawal in pregnancy, but I think 20 years ago, I think people were absolutely terrified of having a pregnant patient experience any form of withdrawal. It's really not as dangerous as we once thought. Unfortunately or fortunately, there's a fair amount of data now looking at actually some correctional systems where people have been taken off their medication when they're pregnant and other sort of causes of withdrawal. And it actually doesn't. The fetus is pretty resilient, and I think we didn't really understand that for years, but it's probably not as dangerous as we once thought. So talking about opiate use disorder in pregnancy, this again, 20 years ago, we knew a lot more about methadone than we knew about buprenorphine. So, when I was starting people in 2007 or 8, I was definitely saying, look, we don't have as much knowledge of how buprenorphine affects the pregnancy. So there was a stronger argument for the use of methadone for that purpose, just because we understood it more in the past, probably less so now. Really important to educate and support the patient with substance use disorder throughout pregnancy. Be aware that there's just usually a lot of other issues present. So social determinants of health needs, co-occurring mental health diagnoses, significant trauma, intimate partner violence. It is important to teach the patient that the infant will remain in the hospital for at least 5 days after birth to be monitored for what used to be called neonatal abstinence syndrome, though the preferred term now is actually neonatal opioid withdrawal syndrome, or NOWS. Patients will have a lot of questions about, is my baby going to go to the NICU? Will my baby be able to stay with me? What will that look like? What are some of the reasons the baby might have to move around? And I would say it's really important to just talk about it. The data is really clear that we try to encourage rooming in when that's safe. So in other words, the baby staying with the mom when that's a safe thing to do from a medical or social perspective. If you work with one hospital in particular, I would say tour your local labor and delivery unit if you don't feel comfortable having these conversations. Because again, this is something that they're really nervous about, and it's just helpful to be able to provide that data. I also talked to all the patients about Eat, Sleep, Console. So that is a monitoring for opiate withdrawal in the infant. We used to use something called the Finnegan scoring system. The ESC, or Eat, Sleep, Console, is a lot easier to use. Basically, sort of at a very low level, it's just determining whether the baby's eating okay, sleeping okay, and are they consolable within a certain period of time. It's a lot more kind of subtle. The first interventions are all non-medical. So it's things like low stimulation, a lot of skin-to-skin contact, swaddling the baby. There's a lot of parent participation, which patients really like. There's also less emphasis on numbers. So I don't know that those of you that are familiar with Finnegan, it was just a sum of numbers. So patients would be like, oh my God, my baby's score went from 8 to 11, and that would be very distressing to them. And there was sometimes a lot of variability across people that were doing the scoring. So I love the fact that there's no numbers, because that was always what patients reported back when they came in. They said, oh, my baby scored an 8 or whatever. And I love that it's just much more patient friendly now. Infants are actually treated with medication, which is typically morphine, far less frequently than they used to be, are typically dosed PRN. Maine has a substance exposed infant notification. For those of you, I'm sure you're all aware. Just be aware that substance use disorder is a major impact for child removals. About half the child removals in the state of Maine involve substance use. We have this mandated substance exposed infant notification. We do prefer the term substance exposed infant, or SEI, drug affected baby, because it usually turned into drug addicted baby. So the better term right now is SEI. That is the elephant in the room. So your patient is wondering what is going on with that. So it's really important to be very honest about it, discuss it early, open, honestly. Like, just people will wonder, oh my God, are you reporting me now? Are you going to report me at delivery? What does that reporting look like? Who's going to know that I got reported? Kind of that whole conversation. So I think I actually start talking about it at the very first visit with patients, so that they're aware of education. I put the specific information on the slide that actually comes to and feel free to read that. I just want to say, globally, in my experience, methadone clinics and sort of the OCFS notification process is often rather bumpy. In particular, sometimes it's hard for OCFS to get information from the methadone clinics. And I 100% appreciate why you're doing that. You're trying to maintain patient confidentiality and support your patients. But I just want to say that sometimes the lack of coordination actually is detrimental to the patient. I've had a couple recent cases, one in which the methadone clinic had reported back to OCFS that the patient had declined the ROI or removed the release of information, when in fact the release had actually just expired, but that information was communicated incorrectly to OCFS, and they almost intervened on that. The second is that oftentimes, because the methadone clinics don't always provide lab results for that OCFS notification process, I've actually talked to patients a lot about, ask the methadone clinic to give you your lab results so that you can take them to meetings and show them. Because oftentimes, again, that coordination isn't really happening behind the scenes. But sometimes they'll run into trouble because somebody will say, oh, it's not certified, it's not directly from the clinic, we can't accept these results. So I just want to reflect upon the fact that the desire to maintain the confidentiality is sometimes detrimental to patients, in my experience. So supporting pregnant patients on methadone, as you all probably know, methadone plasma levels decrease during gestation, and doses may require adjustments during pregnancy. Really critical to normalize this for patients. So I do this with buprenorphine all the time, and certainly talk about it with methadone as well. Their metabolism changes pretty dramatically. I think in particular at the sort of like 19 to 23, 4 weeks period, where people will notice, oh my God, it's not working as well. I feel like I'm getting sick toward the end of the day. Geez, I'm cold and clammy. I'm not sleeping as well. And I just try to tell people, look, you may experience these symptoms, you may not. But patients don't tend to come forward with those issues if you don't kind of open the door for it, because I think people feel like, oh my God, I must be doing something wrong. This is that I myself am bad or something, so that they're not necessarily having that conversation if you don't open the door for it. Split daily dosing is super common. I encourage folks to do that liberally as much as you feel comfortable. The number of times patients really feel dramatically better when they're able to split their dose into morning and afternoon is really remarkable. And I've seen splits of like very small splits, in other words, like 100 in the morning, 20 in the afternoon. That makes a big difference, or kind of more evenly splitting it. And I think just being aware that if you can safely do that with a patient, I would do it as early as you feel like you need to. Again, doses should not be restricted out of concern of worsening withdrawal for the infant. There does not appear to be a dose-response relationship. So again, we don't want to keep people at an artificially low dose to prevent some form of withdrawal. So we know that methadone pharmacokinetics are absolutely altered in pregnancy, but there's to say that there's a specific dose adjustment required. So people say, should I monitor the serum levels? And really, there's no evidence to support that unless there's sort of unusual things happening. So really, patient symptoms should guide the changes in dosing. There isn't some magic to 10 extra milligrams or 20 or 30. It's really patient driven. And that's certainly my experience with buprenorphine as well. So infant outcomes following exposure to methadone during pregnancy. This is probably from the most significant paper that was written on this topic. We do tend to see more NOWs in infants that are exposed to methadone versus buprenorphine. Higher rates of preterm birth, more small for gestational size or small size for gestational age rather, more low birth weight, and there does seem to be a greater risk of neurodevelopmental disorders down the road. No clear evidence of congenital abnormalities other than there does appear to be some evidence for ocular disorders down the road, but treatable strabismus type disorders. From a maternal outcomes perspective, they're actually pretty similar across the methadone and buprenorphine groups. The rates of delivery by cesarean section are similar across the two groups. Rate of severe maternal complications are also pretty similar. People ask, well, why are there differences in outcomes? It's probably related to the fact that in other words, buprenorphine is a partial agonist, methadone is a full agonist. It's been suggested that the more favorable outcomes are because buprenorphine exposed infants are maybe born to women who have less severe OUD, but there's really no evidence to support that. So the thinking is that probably the differences in how the medications behave is the primary cause. So what does this all mean when you're talking to patients? It's the best medication is the one that's best for the patient, hands down, end of story. Like these, I talk openly about methadone, openly about buprenorphine, open about different versions of buprenorphine. We talk about what's best for patients. When I have a patient who's on the inpatient unit at Maine Medical Center, they're going back to a very rural area. I had one fairly recently who, it was going to be an hour and a half drive one way to the methadone clinic. I mean, that's just not feasible for anybody. And so that was not a good choice for her. But if it's locally available, that may be a better option. As a bit of an aside, I think we used to have to go to methadone more because we weren't covering the symptoms in pregnant patients on buprenorphine. I will say I've started using more of the extended release buprenorphine product as kind of a bridge in between, which does seem to cover people with higher demands that might otherwise have had to be referred to methadone. But shared decision-making is essential. So I try to really give pros and cons of all the approaches, kind of what this looks like, and let the patient guide the decision-making. I think so often these women feel very disenfranchised and marginalized, and so I really try to empower them to make the decision that feels best for them. So issues specific to opiate use disorder in pregnancy, all these slides could be lectures on their own, so I'm going as fast as I can. So there's an ongoing question of how prenatal care should be adjusted in pregnancies impacted by opiate use disorder. A lot of folks ultrasound starting at 20 to 24 weeks. We do see that methadone can cause decreased heart rate variability and pure acceleration. So if you're doing something like a biophysical profile, it's probably best to wait 4 to 6 hours after the methadone is consumed if possible. Sometimes if they're doing sort of serial BPPs, they will actually do it in the morning before the dose is administered. So trying to do it at the same time every day so you can see if there's differences in the infant's experience, because we do sometimes see some changes right after the dose is administered. Really important to monitor for common complications. So I think in particular, when I think about pregnant patients with opiate use disorder, they're constipated because they're pregnant, and then they're constipated because they have opiate use disorder, and it is a huge issue. And again, this is not something that people necessarily come in and say, oh, by the way, I haven't had a bowel movement in 6 days. I mean, they're not going to necessarily volunteer that. So opening the door, having the conversation that this may be an issue for them is really important. And you can use standard treatments for it. Fiber fluids, Metamucil, and all that good stuff. A lot of Colace works well. We see a tremendous amount of hepatitis C among pregnant people with opiate use disorder. It's as high as 50% in some populations. I think we ran the study long ago on mine, and it was about 46% of my patients have hepatitis C. Really important to screen for it during pregnancy, and actually universal screening is now recommended for all pregnant patients, so that should be just included in standard screening. Education is hugely important. Patients are fearful, right? So they learn they have hepatitis C, they're pregnant, they're thinking, oh my God, my baby's gonna have hepatitis C. In fact, the vertical transmission rate is actually pretty low, 5 to 7%. It doesn't change how you deliver the baby. It doesn't really change anything about the pregnancy management. It is not recommended yet to treat hepatitis C during pregnancy. I do think we'll see that change at some point. But it's currently the standard of care to treat postpartum. But you can actually now treat all the way down to the age of 3. So when I talk to people about if they have hepatitis C, I say, this puts you at higher risk for complications down the road. But if your infant is one of those 5 to 7% that's born with hepatitis C, they can be treated at a very young age, well before the infant's going to experience any complications. So that tends to be very reassuring to patients. Most patients require IV access during delivery, and this can be hugely triggering to patients, and shaming, right? So they know they don't have good veins because they've spent years with intravenous drug use. I really try to empower patients. If they know they have a good vein somewhere, I say, tell the people who are starting your IV, drawing your labs, say this vein works, and just explain, like be very honest and open about it. But it can be super triggering too. So the act of inserting a needle in somebody's vein when they have a history of a substance use disorder, particularly intravenous substance use disorder, is very triggering. So again, I just try to educate people up front. Like, you're going to probably have an IV. How's that going to make you feel? Like, let's talk about ways in which we can cope with that, or you can talk to your counselor about that. And then just, again, encouraging people, because a lot of people know that vein doesn't work. Like, don't use those. So having that conversation up front can be very helpful. Same dose of MOUD, whether buprenorphine or methadone, should be continued during delivery hospitalization, but it doesn't provide adequate pain relief. Lots of confusion about that. People think, oh, they're on methadone, they don't need any pain meds. Oh my God, that's not true. All the non-opioids can work well. Short-acting opiates can be added very effectively, but likely at higher and more frequent doses. Providers are always hugely fearful of giving too much medication. This happens to me all the time. They'll come to me and be like, oh my God, Alane, I don't want to oversedate her. And I'm like, okay, let's all relax. You're probably not going to. Let's treat her pain like we would treat anyone else's pain. And by far, the greatest risk is actually self-directed discharge due to unmanaged pain. So when I'm talking to people, I say, okay, maybe we're going to make her, a little more sedated than she was otherwise, but if we don't treat her pain, she's probably going to leave. And that is by far the riskiest thing to happen. And so when you kind of talk about it in that way, people tend to be more willing, and you're monitoring these patients closely. Epidurals are a great option for pregnant patients with substance use disorder. The thing you need to know is that epidurals, and I've done a lot of work to try to figure out if there's other meds we can use, but right now most epidurals have fentanyl in it. There's no other medication that can be used, even despite my pleads. So it's really important I talk to my patients because their post-epidural drug screen may very well have fentanyl in it. The baby's first drug screen could have fentanyl in it because of that epidural. So if a patient's really concerned about that, I really encourage them to, when they get to the hospital to deliver the baby, say, I want to leave a urine right now before I have anything done. So there's no question. So just, again, educating patients, because a lot of patients have no idea there's going to be fentanyl in their epidural. And so having that conversation is really important. Methadone should be continued postpartum. The risk of oversedation is largely theoretical. In other words, you don't have to abruptly decrease right after delivery. There was a really good study done on this. It actually showed that the mean dose change in women 12 weeks after birth was only about 4 milligrams lower. So this is not something that needs to be rapidly discontinued or lowered. Treatment disengagement is really common. This is something I fight literally every day. Patients who have their baby, and particularly if they lose custody of that infant, they often sort of go into the wind, and that's a really risky period. Overdose is one of the leading causes of pregnancy-related deaths, particularly in the first year postpartum, especially late postpartum, especially if they've lost custody of their kiddo. So that kind of 9 to 12 months postpartum period, particularly if they don't have custody, is really high risk for drug overdose. Naloxone should be provided, ideally dispensed, in other words, handed right out rather than prescribed. A lot of times people don't pick it up at the pharmacy, so it's great if you can dispense it. Watching the clock here because I know I'm getting to the end. Breastfeeding is recommended for women on methadone if there's no other contraindications. So HIV would be a contraindication. Ongoing illicit substance use would be a contraindication. Hepatitis C is not a contraindication. So again, a lot of confusion about that. If people have hepatitis C, they're good to breastfeed as long as their nipples are not cracked or bleeding. Breastfeeding does appear to decrease the NOWs. It does seem to be the active breastfeeding as opposed to the actual medication being in the breast milk. So it's probably the skin-to-skin contact, the close cuddling of the infant. There is sort of this theoretical risk of a rebound withdrawal if you have a baby that's been breastfed exclusively, say for 3 months, and all of a sudden the baby's going to be removed. There's a risk of rebound withdrawal potentially, but probably a little overstated, but gradual weaning works fine. So patients will say, well, I don't want my baby to go into withdrawal later on or something like that. So we will have conversations about gradual weaning. Co-occurring mental health disorders, again, could be a lecture on their own. They're common and they require treatment. Be aware that many other providers will just stop these medications cold turkey. Like, oh my God, you're pregnant. I had a patient the other day, this classic one, her providers stopped all her psych meds. She's sobbing, and but she said, "Well, my psych provider says I'm doing pretty well." As she's like, tears are running down her face as we're having a conversation. So just be aware that they are often stopped cold turkey. Sometimes patients will stop them cold turkey because they'll be like, "Oh, I don't want to be on that too." Really important to discuss that. This is one of my favorite websites for kind of psychiatric disorders in pregnancy, like which medications are the best or the safest. So I just put that link in there. Monitor for postpartum mood disorders, polysubstance use, super common. Peer support is really important. One of the best things about the mom program, frankly, is the peer support, because I think being able to talk to somebody with lived experience during pregnancy is hugely important. And then a plug to talk about safe sleep in patients with opiate use disorder. It's clear in patients with substance use disorder who go home with their infants that there is this increased risk of sleep accidents. So people who are using cannabis or other things are sort of over sedated, and it could again be somebody in the bed with them that's not necessarily the patient themselves. So just being aware of making sure babies are sleeping in cribs or bassinets or something on their own, because that is an increased risk within this population. And then Main Mom, just want to put in a plug for Main Mom. If you're not familiar with it, it's about 4 years old now. We provide comprehensive care, including medications for abuse disorder, counseling, peer support, and obstetrical care. We try to do it in one setting to really reduce barriers so patients don't have to go to multiple different appointments. They don't have to be on MOUD to be part of it, so they could have a history of an opioid use disorder, nor do we have to be the prescriber. So patients on methadone are welcome to participate. The real goal of Main Mom is comprehensive care coordination. So it's just helping the patient get connected to whatever resources she needs to succeed. A lot of times that's transportation, could be housing, could be working with OCFS in the reporting process. It could be going to family team meetings with the patient after the child's been removed. It could be coordinating with PCPs. It could be setting them up with a psychiatrist for consult, WIC, food resources, safe med storage bags, all kinds of options. So there's a great website. You can find all the programs at mainmom.org. There's a really wonderful video about the program that you can click on there. And so there's some references here. And thank you so much for listening.